Hello, Dr. Donald Murphy here, and welcome to the distance learning session on neurodynamics in patients with low back disorders. The purpose of this presentation will be, number one, to help you understand the role that neurodynamics play in the primary management of patients with spine-related disorders, but we're going to be focused primarily on radiculopathy. Number two, to understand the principles of the application of neurodynamics, again, particularly in patients with lumbar radiculopathy. And number three, to be able to place the neurodynamic approach in the overall context of primary spine care. So be aware that the material in this presentation are covered in this presentation as well as in the book, particularly in chapters 5 and 10. So it's important that you read or have read chapters 5 and 10, as the material in those chapters is part of this entire presentation that we're going to be going through, and you're responsible for the information in this presentation that I'm giving you now, as well as in the chapters in the book. And then we'll be expanding upon this in a practical form in the live Unit 2 that is coming up. So now, the term that we're using here is neurodynamics. A common term that is used that is equivocal to neurodynamics is neural mobilization. And you will hear me use those terms interchangeably sometimes. They mean the same thing, neurodynamics or neural mobilization. Okay, now remember that neurodynamics, that we'll be getting into in a moment, has to be placed in the context of the entire clinical picture. So always when we're talking about any particular aspect of the diagnosis or management of patients with spine-related disorders, we have to put them into the context of the CRISP protocols, which include the 3 questions of diagnosis. So now let's talk about the role that neurodynamics or neural mobilization plays in the context of primary spine care. Primarily, the purpose is to address the answer to diagnostic question number 2 in cases in which the answer to the diagnostic question number 2 is nerve root pain or radiculopathy. And specifically, neurodynamics are applied to patients with subacute or chronic nerve root pain. The neurodynamic approach generally is not applicable for patients with acute nerve root pain. Now the question is, why is this? Why is neurodynamic approaches applicable to patients with subacute or chronic nerve root pain, but not for patients with acute nerve root pain as a general rule? So think about that, and we'll get to more information that will clarify that in a moment. Now, the other important thing here is that neurodynamic or neural mobilization is designed to address the answer to diagnostic question number 2, specifically when the answer to that question is nerve root pain is contributing to the overall pain, disability, and suffering experience that the patient is experiencing. But we have to remember that we need to address these factors in relation to other factors related to diagnostic question number 2, as well as any factors that may be relevant with regard to diagnostic question number 3. So the neural mobilization or neurodynamics must be thought of and acted upon on the context of any other factors that may be related to diagnostic question number 2 and any factors that may be relevant to diagnostic question number 3. So remember the pathophysiology of radiculopathy. When we talk about the pathophysiology that is discussed in the book as well as in our distance presentations and our live presentations, we talk about that in patients with acute nerve root pain, by and large, the pathophysiology focuses primarily on acute inflammation, whereas in patients with subacute or chronic radiculopathy, where they have nerve root pain that is subacute or chronic in stage, the pathophysiology focuses primarily on congestion and fibrosis. And this gets to what we were talking about earlier with regard to why is neural mobilization appropriate for patients with subacute or chronic stages and not in acute stages. And this is the reason. It's the pathophysiology difference, the pathophysiological differences between acute and subacute or chronic. Generally, it is not appropriate to mobilize a nerve root that is undergoing active acute inflammation. Once the stage transitions into subacute or chronic radiculopathy, that is the point in which neural mobilization or neurodynamics is relevant. So when we're applying neurodynamics, the purpose is to mobilize the involved nerve root for the purpose of increasing the mobility of the nerve root. Number two, improving the circulation and reduce the edema within the nerve root. To desensitize the nerve root. So these are the three primary purposes of applying neurodynamic processes in patients with radiculopathy, to increase mobility, to improve circulation and reduce edema, and to desensitize the nerve root. So the question that arises naturally is it possible to mobilize a nerve root? And the answer is yes. Studies have shown that maneuvers, specific maneuvers that we will be talking about, apply mobilization maneuvers to the nerve root, but remember that the neurodynamic maneuvers are not restricted to just the nerve root, that the movement is applied to the peripheral nerves, to the plexus, to the nerve root, as well as to the spinal cord. So the entire neural tract is mobilized when we perform neurodynamic movements, not just the nerve root. So now, there are several general principles of neurodynamics that if we can understand each of these principles, then we will understand the big picture, the overall picture of neurodynamics. So it's very important to understand each of these types of principles. Number one, the types of neural movements. Number two, the types of maneuvers that we apply when we're applying neural mobilization. Number three, the methods by which we apply neurodynamics. Number four, the location of the focus of our movement maneuvers. And number five, the nerve root complex that is involved in the neurodynamic process. So what we're going to do now is look at each of these principles individually so we can understand exactly what each of these principles are and how they apply to neurodynamics. So principle number one, the types of neural movements. So there are two types of nerve root movements that occur during neurodynamics. One is movement of the nerve root within the canal. So this nerve root is pictured here in blue, and one of the manners in which we apply neurodynamic is by moving or mobilizing the nerve root within the lateral canal. The second type of neural movement is intraneural movement, and that is movement of the individual axons and the individual fasciculi of axon bundles. So movement occurs not only in the nerve root itself as a whole, the nerve root as a whole, but also the intrinsic structures within the nerve root. So principle number one, the types of neural movement involve both the nerve root as a whole as well as the intrinsic aspects of the nerve. Principle number 2, the types of mobilizing maneuvers. There are flossing maneuvers and there are tensioning maneuvers. A term for flossing maneuvers sometimes is you'll see the term gliding or the term sliding. So the term gliding and the term sliding can be seen as synonymous with flossing. So there's two types of mobilization maneuvers that we apply: flossing maneuvers and tensioning maneuvers. So what are flossing or gliding or sliding maneuvers? These are maneuvers that focus on mobilizing the nerve root as a whole within the lateral canal. So in order to apply these flossing maneuvers, we slacken one end of the neural structure, while at the same time tensioning the opposite end of the neural structure. So in other words, we're going to slacken from the proximal side while we're tensioning from the distal side. That allows the nerve root to move outward in the canal. And then we reverse it by slackening the peripheral aspect of the neural structure and causing tensioning on the opposite side of the neural structure, which causes the nerve root to move medially within the canal. And again, this may be somewhat difficult to visualize right now, but this is discussed in detail in the book, and we will cover it in detail in the live portion of the course. So again, the second type of maneuvers that we apply are tensioning maneuvers. And again, theoretically, this focuses primarily on the intrinsic structures within the neural structure. And this is where we stabilize one end of the maneuver while at the same time tensioning the other side. So this allows for some movement of the neural structure as a whole, but minimizes movement of the neural structure and focuses primarily on mobilizing the intrinsic structures within the nerve root. Okay, principle number 3, the methods of neurodynamics. So basically there are two methods. 1, exercises. 2, manual maneuvers. And very, very important in the overall context of management of patients with spine-related disorders is focusing primarily on maneuvers that the patient can apply themselves. And one of the beautiful things about neurodynamics is once we've established some of the mobility and decongestion and desensitization of the nerve root, we can very quickly transition to teaching the patient how to perform these maneuvers on their own, which not only helps to repetitively mobilize the neural structure, but also importantly to increase the patient's self-efficacy, which you have heard us talk about already, and will hear us talk about greatly and frequently in the future. Increasing self-efficacy is a very important aspect of managing the patient with spine-related disorders and helping them overcome the problem. And we'll get into that as we go along. Okay, principle number 4 is the location of the focus of movement. And this can be proximal. Mobilizing the neural structure proximally means focusing primarily on the aspect of the neural structure that is proximal. So in this case, it's a neurodynamic procedure that involves the sciatic nerve, and the movement is focused primarily at the hip. So the movement of the lower extremity is in flexion, extension, repetitively of the lower extremity, which focuses the mobilization at the proximal end. Second is intermediate maneuvers. and this is where the focus of the maneuver is somewhere in the middle section of the neural structure. In this case, is an example of mobilizing the nerve roots by utilizing the sciatic nerve, and here it involves moving at the knee. So the lower extremity is extension and flexion at the knee, which helps to mobilize the sciatic nerve and ultimately mobilizes the nerve root. And then third, distal maneuvers, and this is where the neural structure is primarily mobilized by focusing at the distal end of the neural tract. What's illustrated here is, again, applying neurodynamics to affect the nerve root by utilizing the sciatic nerve, and here in this example, focusing the mobilization at the ankle. So the foot is dorsiflexing and plantar flexing, dorsiflexion and plantar flexion, dorsiflexion, plantar flexion repetitively to mobilize the sciatic nerve distally, which ultimately applies mobilization maneuvers on the nerve root. Okay, principle number 5, the nerve root complex that is involved. So as you've seen already, and we'll talk about in principle number 6, in order to apply mobilization maneuvers to the nerve roots, we utilize the peripheral nerve to apply these maneuvers. And so in patients with low back problems, the two plexes that can contribute to the peripheral nerves are the lumbar plexus, which involves the femoral nerve and is contributed to by nerve roots at L2, L3, and L4, and the lumbosacral plexus, which contributes to the creation of the sciatic nerve and is contributed by L4, L5, and S1. Now, what you'll notice here, of course, is that L4, the L4 nerve root, can contribute peripheral nerves to either the lumbar plexus or the lumbosacral plexus, and in most cases, both. So some of the L4 nerve roots are contributing to the sciatic nerve, some are contributing to the femoral nerve. So now, when we are applying neurodynamic maneuvers to the patient, we can either use the sciatic nerve or we can use the femoral nerve. But how do we know that? How do we know which peripheral nerves are being contributed by the nerve root? Well, we know that is through the neurodynamic exam. So the neurodynamic exam will tell us how to apply the neurodynamic maneuvers when we're treating the patient with radiculopathy. And that will become clear in a second. But before I get to that, I'm going to remind you of the barrier concept. And you may have seen and listened to already, or you may that may be coming up, the separate distal learning presentation on the barrier concept. And the barrier concept applies to all patients in which manual therapies, or exercises for that matter, but especially manual therapies, are being applied. So with the barrier concept, what we're doing is working with our manual maneuvers at the point at which we initially perceive resistance. So what's pictured here is a neurodynamic maneuver that is utilizing the sciatic nerve in order to apply mobilization to the involved nerve root. And what we want to do is dorsiflex the ankle and flex the leg and raise it to the point at which we first perceive resistance from the neural structure. And that means we need to get in touch with and be able to really feel what is happening mechanically to the structure that we're lengthening and mobilizing, and when we reach the point at which we can initially perceive the resistance, that is the point at which we meet the barrier. Now, as we apply mobilization maneuvers at the barrier, what typically happens, either during the course of an individual session or over the course of several sessions in a row, there becomes an amplification of the release of the barrier, which means that the initial perception of resistance happens later in the process or later in the movement that we are applying. And so, in other words, to again use this as an example, as the barrier release, it takes a greater amount or amplification of straight leg raise with ankle dorsiflexion in order to reach the point of barrier. Now, in some patients, the patient perceives the point of the limit of her tolerance of maneuver before the point in which we initially engage the perception of the resistance. So if that's the case, then we perform our neurodynamic maneuver, at least in the beginning, at the point of the patient's tolerance, not necessarily at the point of our perception of resistance. So there are some patients whose neural structure is sensitive enough in which they feel fairly significant discomfort at the point before we initially perceive resistance within the neural structure. And if that's the case, then we go by the patient's tolerance, at least in the beginning, until their tolerance improves, in which case we usually gradually reach the barrier that we can perceive when we perform the movement. And again, I'll repeat, the barrier concept is covered in detail in another distance learning module, and we will be going this into great detail from a practical standpoint in the live portion of this unit. Okay, so if the examination that we undergo, the neurodynamic exam, led to our ability to reproduce the patient's pain with the straight leg raise and its structural differentiation, and we've learned this in a separate module as well as in a separate unit. If in any individual patient it's the straight leg raise and its structural differentiation that leads to reproduction of the patient's nerve root pain, then that tells us that sciatic nerve mobilization is the manner in which we will be mobilizing the involved nerve root, either with manual maneuvers or with patient-generated movements. If on neurodynamic exam, the maneuver that reproduced the patient's pain, nerve root pain, was the femoral nerve stretch test and its structural differentiation. So FNST stands for femoral nerve stretch test. So if during our neurodynamic exam, the femoral nerve stretch test and its structural differentiation allows us to identify the presence of nerve root pain, then we know that the neurodynamic maneuvers are going to be utilizing the femoral nerve for applying mobilization. So here's an example of an exercise in which the femoral nerve is being utilized to mobilize the involved nerve root. So again, how do we know when to use the sciatic nerve mobilization maneuvers versus the femoral nerve mobilization maneuvers? Well, what tells us that is what was the result of the neurodynamic exam. Again, if the reproduction of the patient's nerve root pain resulted from our utilization of the straight leg raise and its structural differentiation, then we know that sciatic nerve mobilization is going to be applied when we perform neurodynamic treatments. If the nerve root pain was reproduced by the femoral nerve stretch test and its structural differentiation, then we know that the femoral nerve is the structure that we're going to be using in neuromobilization to apply treatment to the involved nerve root. And I'll remind you of context. The neurodynamic examination and the neurodynamic treatments that we've been talking about here and that is covering in detail in the book and that we will be covering in the live portion of this unit must be placed in the overall context of the diagnosis and management of the patient who may be suffering from radiculopathy. So we need to consider diagnostic questions number 1, number 2, and number 3 in all patients and at all points along the process of managing the patient. Okay, so once again, in this distance learning module, our objectives were to helping you to understand the role that neurodynamics play in the management of patients with spine disorders, especially with lumbar radiculopathy. Number 2, understand the principles of neurodynamics, particularly in patients with lumbar radiculopathy. And number 3, to be able to place the neurodynamic approach in the overall context of primary spine care. Thank you for your time.